Hello students, today I'll be taking a class on ameloblastoma. Ameloblastoma is the most common odontogenic tumor and it comprises of 1% of all oral tumors. I'm going to deal with ameloblastoma under the following contents: definition, histogenesis, its classification, radiographic features, histologic features, differential diagnosis, treatment and prognosis, and miscellaneous wherever it is applicable. Ameloblastoma was defined by Robinson as under the 5 categories that he described ameloblastoma as unicentric, a lesion which is unicentric, non-functional, intermittent in growth, anatomically benign, and clinically persistent. So these are the 5 definitions under which, these are the 5 titles under which Robinson defined ameloblastoma. Again, there are 5 histogenesis from which the ameloblastoma is thought to arise. So because ameloblast arise from the enamel organ, so most of the things are limited to these 5 things. The first one is the cell rest of enamel organ, that is cell rest of dental lamina known as cell rest of Ceres, and cell rest of molasses from Hertwig's epithelial root sheath. Epithelium of odontogenic cysts, especially the dentigerous cyst. Any disturbance in the developing enamel organ, physical, chemical, or any of that sort. Basal cells of the oral mucosal epithelium, considering that enamel organ resulted from the descent of dental lamina, which was because of the proliferation of the basal cells of the oral epithelium. So, basal cells of oral mucosa is thought to be one cell of origin. Heterotrophic epithelium, such as cells in the Rathke's pouch, in the pituitary gland, are thought to share certain lesions. So, we can expect to see ameloblastoma-like lesions in those areas. In classification, we can classify ameloblastoma based on clinical categories and radiographic categories. I have tried to combine both of them and give you a simplest classification based on clinical appearance. Conventional, which something occurs most amount of time because this lesion tends to affect around 86% of the time. Majority of the cases tends to be conventional. Okay, they tend to be solid in nature. The solidness in radiographic feature appears as multicystic lesions. These are intraosseous multicystic lesions. Okay, so 2 clinical and 2 radiographic terminologies being used. Similarly, intraosseous, instead of having multicystic, if you tend to have a unicystic lesion. Multicystic, many cyst, unicystic, single cyst. Okay, so this comprises of the next smaller percent of cases, a very small percentage of cases, that is 13%, known as unicystic ameloblastoma. Then we have the extraosseous type of ameloblastoma, that which occurs outside the jaw bones in the soft tissues, that is inside the gingiva, the closest soft tissue to the jaw bones. Extraosseous ones, peripheral lesions around very small, 1% of the cases. Now, moving on with the conventional type of ameloblastoma, which happens to be solid and multicystic. It tends to occur in the age group of 20 to 40 years. Males and females are commonly affected. For some unknown reason, it tends to occur more commonly in the blacks. Mandible is more commonly affected than the maxilla, and in the mandible or in the maxilla for that matter, posterior region is more commonly involved than the anterior region. These tumors, ameloblastoma, a benign tumor, it tends to be by definition asymptomatic, painless swelling of the jaw bones, expansion of the jaw bones, slowly destructive, usually not ulcerated. It will have an intact mucosa, but some forms of ameloblastoma, which tend to be very aggressive, can show you ulceration of the oral mucosa. There will be resorption of the roots of the teeth. This is a useful distinction, a key feature for the useful distinction of lesions which occur in this particular area in other cysts and tumors, which are more commonly occurring in the posterior part of the mandibular area. So palpatory finding, because this lesion is unicentric as in the definition, so it tends to involve both cortical plates equally. So the cortical plates, there is thinning of the cortical plates that gives rise to the crepitus or the egg crackling feeling on palpation. So here we have an ameloblastoma in the posterior part of the mandible, and a huge lesion. Here we can see that the surface area is intact, and here we can see ulcerations. This is a very aggressive granular cell ameloblastoma that I'm showing you right now. Radiographic features. It tends to present itself as a multilocular cyst-like. See, this was the classic or the conventional type I was talking about. So if you can appreciate over here, look at this. Small areas. If you've observed honeycomb appearance, this is how it is. Soap bubble or honeycomb. When we mix up the soap and when we allow the lathers to form, you will have numerous bubbles that form, just like honeycomb or the thing, hence the name honeycomb appearance or soap bubble appearance that comes in this multilocular lesions. Okay, so it's a radiolucent lesion surrounded by a sharp radiopaque border. See, all these dark black areas are radiolucent areas, and the borders of it are radiopaque areas. Okay, so this is one large one. If you can appreciate it here, see, numerous ones present, and this mandible is so involved that the lesion is going, the radiolucency is going down to the base of the mandible. Bony margins typically tend to produce a scalloped appearance, like DEJ, the scalloping that we get, no? It tends to present in that particular form. Roots of the adjacent teeth may be resorbed or displaced. In this particular diagram, if you observe, we see a single unilocular radiolucency. So this is an example of unicystic ameloblastoma. So see over here, only one single radiolucency bordered by a nice thick radiopaque border. Roots of the adjacent teeth may be resorbed or displaced. You will see that there is uniform expansion of both lingual and buccal cortical plates, a very common, a very important feature to differentiate between other cysts and tumors that can occur in this particular region, because almost all the other lesions will tend to involve only the buccal cortical plate without involving the lingual cortical plate. Only ameloblastoma tends to involve both buccal and lingual cortical plate. Again, a nice unilocular type of ameloblastoma. This is to show the involvement of the cortical plates. See, both buccal and lingual cortical plate are involved. Look at the expansion here, huge. This is just to show you that how thin the lingual cortical plate. See how thick it is in the normal side. In the affected side, there is thinning. Only ameloblastoma tends to does that because it has got that unicentric growth potential. Histopathologically, there are 6 subtypes of ameloblastoma: follicular, plexiform, acanthomatous, basal cell, granular cell, and desmoplasmic type. Usually, ameloblastoma tends to present itself as mixture of both epithelium and ectomesenchyme surrounding it. So the lesion can present in the 6 histopathological pattern. We may see overlapping of 1, 2, or more than 2 patterns that coexist to each other. So assigning the name or the grade of the lesion depends upon the type or the pattern which predominates mostly in the lesion. So follicular ameloblastoma, the ameloblastoma is an epithelial cell. So we'll see that odontogenic epithelium will be arranged in the form of follicles. See, all these are follicles, and these follicles are separated by connective tissue, ectomesenchymal connective tissue. Okay, so numerous follicles seen surrounded by the ectomesenchyme. Why do we call it as odontogenic? Because it tends to show odontogenic cells of odontogenic apparatus. That is, peripheral. Here you can appreciate that in each follicle you can say that there are 2 layers of cells, peripheral and central. The peripheral layer of cells tend to present themselves as tall columnar cells presenting with reversal of polarity. Now, which cell tends to show that feature? It is the ameloblast-like cell, tall columnar cell with reversal of polarity and a dark staining that comes, dark stained nucleus comes. That is a classic feature of an ameloblast. So, the peripheral cells resemble ameloblast. So, we call them as ameloblast-like cells. Remember, they are not typical ameloblasts. They are ameloblast like cells. Central cells, you can see that there is a lot of intercellular spacing and reticulate appearance. So they appear like stellate reticulum like cells. So in between the follicles, you will see huge cystic spaces. Cystic degeneration can be appreciated. Again, see peripheral ameloblast like cells and center stellate reticulum like cells. Acanthomatous ameloblastoma is an extension of follicular ameloblastoma where there is additional feature, that is some of the um, stellate reticulum-like cells undergo metaplasia to become squamous cells. So how is a squamous cell different from a stellate reticulum? Stellate reticulum is a pale staining cell with a lot of intercellular edema around it, whereas a squamous cell is a cell which is filled with numerous cytoplasm. So see over here again, even in acanthomatous ameloblastoma, the epithelium will be arranged in follicles, numerous follicles. You will see that there is peripheral layer of ameloblast-like cells, central stellate reticulum-like cells, but amongst them, amongst the central stellate reticulum cells, some of them undergo squamous metaplasia. So they start showing a lot of pinkness because cytoplasm becomes filled with keratin. So it is going to be pinkish in nature. Here, a better one, peripheral ameloblast-like cells, stellate reticulum-like cells getting sandwiched between these squamous metaplastic cells. Okay, here you can see again ameloblast-like cells, stellate reticulum-like cells, and squamous metaplasia with keratin formation. See, this is a typical squam cell. See, there is no business of stellate reticulum cells to be appearing like this, but they do in this particular condition. So see, peripheral ameloblast-like cells, stellate reticulum-like cells, squamous metaplasia, keratin formation, individual cell keratinization. Granular cell ameloblastoma, yet again, granular cell ameloblastoma is also a type of follicular ameloblastoma. Again, you see peripheral layer of ameloblast-like cells, central stellate reticulum-like cells, and in between these cells, some of the cells undergo transformation to become granular cells. What are granular cells? Those cells that tend to present themselves those cells that tend to show a granularity to the cytoplasm, like a sandpaper texture you get. You would be able to appreciate it in this particular diagram. See over here, the cytoplasm, which is supposed to be homogeneous, tends to become particulate like this, like a sandpaper texture, as I told you. And these cells are called as granular cells. Variety of cells tend to assume this because of a change in the internal composition of the cell, giving rise to granularity to the cells. So this granular cell ameloblastoma is the most aggressive form of ameloblastoma because it tends to show enzymes, lysozymal enzymes, which breaks the islands and spreads. The huge lesion that I showed you in the clinical picture first is of a granular cell ameloblastoma. Because of its spreading nature, it is the most aggressive subtype of ameloblastoma. Desmoplastic ameloblastoma is the least aggressive type of ameloblastoma. Here also, the ameloblastic islands, ameloblasts are seen as follicles and islands and scattered in a dense fibrous stroma. Why dense? Because look at the term, split up the term, desmoplastic. Desmo means band. What gives rise to band? Fibrous bands. Okay. Plastic or plasia means formation. So formation of dense fiber bundles in the around the ameloblastic islands is called as desmoplastic ameloblastoma. So now look at this follicles and look at the quality of the collagen fibers. Dense, isn't it? So now imagine you take a rubber band and you tie it to the cover. What happens to the opening of the cover? It gets shrunken up and becomes reduced. Same thing is happening to your odontogenic islands as well. Thick fiber bundles is reducing and clumping and shrinking off the size of this. So it may be so severe that you will be appreciating only a double layered cell, and in these conditions it's very tricky to make out the peripheral ameloblast like cells and central stellate reticulum like cells. Please call through the whole of the field. You will be able to appreciate it at one or the other point, so it should not be an issue. So this is one. See, instead of having tall columnar cells, what is happening? You have flattened cells. So until I see a tall columnar cell, until I see a cell which looks like ameloblast, I cannot call it as ameloblastoma. So that would be a limitation. But again, as I said, if we scroll through the whole of the field, we will definitely come across such islands. Basal cell ameloblastoma, it is the least common type of ameloblastoma, occurs primarily in extraosseous locations. Remember, the peripheral lesions or the extraosseous lesions of ameloblastoma, the 1% cases that we were talking about, usually they tend to be basal cell ameloblastoma. Now, why do we call it as basal cell ameloblastoma? Because instead of having tall columnar ameloblast-like cells with reversal of polarity, we see basaloid type of cells. What are basaloid type of cells? Cells which tend to show you that a tall columnar cell with reversal of polarity will be an ameloblast, whereas a tall columnar cell with a centrally, not a very tall columnar, but a columnar or more cuboidal cell with a dense staining nucleus occupying almost two-thirds of the cytoplasm will be a basal cell. Because the nucleus is a very prominent structure inside the cell appears to be bluish in nature. Now look at this. All these are ameloblastic islands. But what is happening? What strikes to your eye? The blueness is what strikes to your eyes because the whole of the odontogenic island is transformed into basaloid type of cells. So you're not able to appreciate the peripheral cells or the central cells in this manner. Now look at this. All basaloid cells. Center also, there is no stellate reticulum like cell at all. Okay, so here there is a confusion that can arise, but again scroll through the whole field. Definitely in some island you will be able to appreciate stellate reticulum like cell, and then we can call it as ameloblast. Otherwise the diagnosis can be quite tricky and falls under the category of numerous differential diagnosis. In plexiform ameloblastoma, the odontogenic epithelium, instead of being arranged into follicles, they are arranged as plexus, like how we plait hairs. So there is intertwining of the odontogenic islands, giving rise like meshwork kind of a pattern. So there is interconnecting or interlacing of the odontogenic epithelium. Look at this. This is the odontogenic epithelium, and this is the plexing of the odontogenic epithelium. The connective tissue happens to be very delicate, very sparse, but very vascular. So look at this. Lot of blood vessels. Whatever you're seeing over here are all blood vessels. See over here again, plexus of ameloblast islands, lot connective tissue, and lots of blood vessels. So in follicular ameloblastomas, usually the cystic changes occurs inside the follicles, inside the epithelial cells. Whereas in plexiform ameloblastoma, the cystic changes are seen in the connective tissue because of the rich vascularity that we get to see. So ameloblastoma can be differentiated from CEOT, the radiolucent type, odontogenic myxoma, a common odontogenic tumor, cysts, such as the most common one being the radicular cyst, to dentigerous cyst, to the odontogenic keratocyst. We can also confuse them with, we can also try to rule out central giant cell granuloma, ossifying fibromas, central hemangiomas, and squamous cell carcinomas as well, especially the acanthomatous type because it tends to show follicles with squamous cells and keratin pearl formation. So we need to be very careful about that. Treatment and prognosis, aggressive lesions, that is the require extensive treatment, wide excision, resection of the jaw may be required. Recurrence is quite a common feature, especially with the um, granular cell variant. Now moving on to the next category, that is the unicystic ameloblastoma. 10 to 15% of unicystic, a very small proportion of cases of ameloblastoma tend to be unicystic ameloblastoma. How is it different from the typical conventional ameloblastoma? Not just in the radiographic sense of unilocularity, but also in age. Usually ameloblastomas, unicystic ameloblastomas are seen in younger age group people, second decade, third decade, first decade. There it is very common. Males tend to be more commonly affected than females, unlike the ameloblastoma where males and females can be commonly affected. Sight remains the same, posterior part of the mandible. Clinical features remains the same because it is again the same benign type of odontogenic tumor, that it is painless swelling and mostly asymptomatic. Pathogenesis, it arises de novo, or it can arise from the lining of a cystic epithelium such as dentigenesis that I've already mentioned. Clinical features, younger age group, as I mentioned, more common in the second decade of life. Mandible, almost 90% of the cases tends to occur in the posterior part of the mandible. Higher percentage of cases, a lot, if not all cases, most of the cases will be associated with an impacted tooth in this particular region. So because of the unilocularity, lesser age, it's most often confused with dentigerous cyst. So radiographically, as I told you, the whole idea of classification and the whole idea of naming this lesion as unicystic is because it tends to produce a unilocular, well-defined radiolucency. Most of the times, there is an associated floating impacted tooth. Histologic features here, the lining, same follicle, imagine peripheral cells, ameloblast like cells, central stellate reticulum like cell. If I cut it into half and open it, what will be there? Basal cells will be ameloblast like cells and suprabasal are stellate reticulum like cells. That is the lining. So the simple lining type of ameloblastoma, unicystic unilocular ameloblastoma, tends to present the single cystic cavity that shows ameloblastomatous differentiation in the lining. There are three types of unicystic ameloblastoma: luminal type, intraluminal type or plexiform unicystic ameloblastoma, or mural type of ameloblastoma. Now observe this. If the changes is limited, ameloblastic lining epithelium is limited only to the lining of the cyst, only in the cyst, then it is called the luminal type. If the same lining epithelium, instead of being lining the cyst, if it projects into it as well, it is known as the intraluminal type of ameloblastoma. Lining as well as projection into the lumen makes it intraluminal. Mural type, when the apart from lining epithelium, when we are able to appreciate ameloblastic islands inside the or below in the connective tissue, then it becomes the third type, that is the mural type. Why do we have to differentiate type 1 and type 2? That is the luminal and the intraluminal type will be treated very simply with the cauterization and all that. It's more than sufficient. It's not going to recur. Treatment is very simple. But the type 3 one, that is the mural type, has to be treated like a typical ameloblastoma, which happens to be resection. Okay. So in order to identify ameloblasts, there is a criteria known as Vicker-Collins criteria, which helps in identifying a cell as ameloblast. So the criteria is, first of all, you need to have, one second, you need to have tall columnar cells. These columnar cells have to be arranged parallel to each other. Okay, there should be reversal of nuclear polarity. That means the nucleus should move in the opposite direction to that of the basement membrane. Okay, and the nucleus that is present will be hyperchromatic as well as nuclear palisading, because the cells palisade are so parallel to each other. The nucleus also tends to show that palisaded or parallel kind of arrangement. And just beneath the nucleus, we will appreciate a subnuclear halo because of the cytoplasmic vacuolation, because that is the space where a lot of Golgi complexes will be present. Golgi complexes bodies are made up of lipid, which H&E doesn't stain. Hence, there is this vacuolation. So all secretory cells usually tends to show this kind of an effect. So H&E images, luminal ameloblastoma, see the lining, the ameloblastomatous epithelium is found only in the lining of the cyst. Intraluminal, see, apart from the lining, there is projection of this ameloblastomatous epithelium into the cystic area. So there, mural, apart from the lining epithelium, it also projects and extends into the underlying connective tissue. Okay, type 3A, type 3B. Look at this. extensions of ameloblastoma islands apart from the lining epithelium into the underlying thing. So the differential diagnosis happened to be radicular cyst, residual cyst, dentigerous cyst, and odontogenic keratosis, purely because of the site appearance, because of the site in which they occur. Treatment and prognosis, type 1 and type 2 can be successfully treated with enucleation and curettage alone, carrying very less chances of recurrences, but type 3 has to be treated like a typical ameloblastoma with surgical resection, excision and resection. Other types, that is type 1 and type 2, will show a very low recurrence rate. Long-term follow-up is required just to make sure that the lesion doesn't recur back. Peripheral or extraosseous ameloblastoma, as I've told you, it is uncommon and comprises of only 1% of the tumors. This originates either from the remnants of dental lamina or from the surface epithelium. That is the basal cells that I was talking about in the cell of origin. Usually the lesions which tend to occur on the gingiva or alveolar mucosa in case teeth are absent. Size is going to be very small, less than 2 centimeters in size. More common in the mandible than the maxilla. See over here, a simple growth of gingiva like this. Most often excisions of projections or proliferations of gingiva are discarded on biopsy, assuming them to be either a fibroma or a pyogenic granuloma, but they could be a lot more than that. Hence, it is advisable that all biopsies of the gingiva or any other tissue should be backed up by a biopsy report. Okay, radiography, it occurs in the soft tissues, but because of the pressure effect, it may bring about superficial erosion of the jaw bones, hence saucerization effect can be seen. Histopathologically, the peripheral forms tend to be mostly acanthomatous type and then plexiform or follicular in that descending order. So you can see surface epithelium of the gingiva, lesional tissue surrounded by a completely normal connective tissue. Lesional tissue separated from the overlying epithelium by a normal connective tissue that is known as the Graham zone. So that is usually a representation of peripheral lesion. Differential diagnosis, peripheral odontogenic fibromas, but there it lacks polarized cells and there is production. Production is a no-no for ameloblastoma because ameloblastomas need odontoblast to become functionally active and to produce enamel. Treatment and prognosis, they are relatively innocuous clinical behavior, low recurrence rate. Extraoral tumors resembling ameloblastoma can be found elsewhere in the body, especially in two common sites known as Rathke's pouch tumor or craniopharyngioma, where the lesions tend to affect in the pituitary gland. What are the features there? Copious amount of ghost cell production, cystic morphology, and presence of osteoid and bone. So inside the jawbone, production of hard tissue is a complete uh, uh, negative character of ameloblastoma, but when it does occur in other outside the oral cavity, we get to see not tooth-like tissue, but some kind of a hard tissue will be appreciated. Same thing with the long bones. It is known as adamantinoma of long bones. They lack the regular shape and reverse nuclear polarity of ameloblastoma cells. Okay, so the takeaway points for today's lecture is ameloblastoma definition, which is very important. The Robinson definition has to be produced. The 6 histopathological subtypes of ameloblastoma is very important. Most of the time, short notes are being asked directing towards this particular question. Unicystic ameloblastoma by itself is a good entity to be asked as a short notes, or it can be a main question along with classification of odontogenic tumors. Ameloblastoma is a very important topic. There are two types of ameloblastomas, malignant forms of ameloblastomas as well. They are known as malignant ameloblastoma and ameloblastic carcinoma. Malignant ameloblastoma, where the metastatic islands resemble the parent cells, the benign tumors. Then if the lesion is benign appearing, why call it malignant? Because it has metastasized. One of the most important feature differentiating between benign and malignant tumor is property of metastasis. A benign tumor will never metastasize. A malignant tumor, no matter how benign it appears, it is going to metastasize. So because it is metastasized, we call it as malignant ameloblastoma. Ameloblastic carcinomas are lesions where we get to see a lot of dysplastic properties, both in the original site as well as the metastatic tissue. Both of them show a lot of cellular differences, such as altered nuclear cytoplasmic ratio, hyperchromatism, mitotic figures, and so on. So that is the difference between malignant ameloblastoma and ameloblastic carcinoma. So thank you.